This program is brought to you by Emory University.
Good morning, everyone. It's my pleasure to introduce Lakshmi Tummala today, who is at Grady Memorial Hospital, an assistant professor of medicine. She received her medical degree from Northwestern University and completed her internal medicine residency and chief residency at New York University, followed by a cardiovascular disease fellowship and chief fellowship at Georgetown. She joined the staff at Grady in 2020. And she's currently serves as the medical director for Grady's ambulatory care cardiology clinic. She also co-directs the School of Medicine cardiology course and does an amazing job because I know that she sends me emails about how to improve my presentation to med students, and it's just wonderful to work with her on that. She serves as the fellowship program associate program director also for our fellowship program. She has a clinical and research interest in cardiac obesity and cardio obstetrics. And currently, she's also pursuing a master's of education in health professions. She really is an advocate for women in medicine. And I heard this talk, or at least parts of this talk, when she gave it last year at our Women's Heart Disease Conference. And I thought it was an amazing talk, and we all need to know how to treat obesity. And so I'm looking forward to this talk. I'll turn it over to you, Lakshmi.
Thank you so much for the kind introduction and for the opportunity to share with you today about something that I feel very passionately about. Good morning. So I grew up in a small town in Alabama, about 30,000 people. My father still practices gastroenterology there. And I remember when I was little hearing him say that weight was a major concern of his and that he really wished he could just help his patients lose some weight. And now I feel like 30 years and 3 certifications later, I get it. I think we've gotten so frustrated by the poor response to our attempts to help our patients lose weight that we've kind of given up and stopped trying. And although we know there is an obesity epidemic, I think like the alarms have been blaring for so loudly and so long that they've sort of been reduced to background noise. So my goal for today is to kind of pause, take a look at what we know about obesity, and then help all of us figure out what we as cardiologists can do to help our patients lose weight. All right. So obesity has been around for a long, long time. It's not a new disease process. I'm going to tell you a little bit background information to make sure we're all on the same page. We'll discuss the pathophysiology of obesity and why I'm really excited about weight loss medications. I'm going to follow that up with some practical tips about nutrition because I feel like this is one of those areas where it can be difficult sometimes to translate the information we have into actual patient care. And then I'll close with what I mean by a call to action. I'm not going to have time today to talk about physical activity, sleep, psychology, social determinants of health, or bariatric surgery, but I do want to acknowledge that these are crucial parts of the conversation about obesity. All right, so this is a map that all of us know very well, cardiac mortality in the United States. And this is a map of the prevalence of obesity, which is basically the exact same. In our country, more than 1/5 of the population has obesity. And in Georgia, that prevalence is 37%. That means on an average clinic day, you are seeing at least 11 or 12 patients who meet the criteria for obesity. Obesity is also expensive. We spend more than $170 billion on it annually. For context, I've included some numbers here for coronary artery disease, heart failure, and atrial fibrillation, which totaled do not add up to the cost of what we spend on obesity. It is also a risk factor for mortality, both total death and cardiac death after correcting for comorbidities. So if we look at our history of treating obesity, we've been trying to cure this problem since the 1950s. By the 1960s, we had a pretty successful precursor to the Roux-en-Y bypass surgery. And in the time since then, we've innovated gastric bands and balloons and several different types of bariatric surgeries. Today, we know that bariatric surgery, bariatric surgery can cure hypertension, hyperlipidemia, and diabetes. It reduces overall mortality and cardiovascular mortality, and it can reduce both primary and secondary events for coronary disease, heart failure, and atrial fibrillation. Okay? That being said, only about 1% of patients who are clinically appropriate for bariatric surgery actually get referred and undergo the procedure. So why is that number not higher? These are my thoughts. One, there's still a stigma associated with bariatric surgery, this idea that you don't have the willpower to lose weight, and that's why you need this treatment. It is a big change. There are complications because it is an invasive procedure and it's variably covered by insurance. Currently in our country, the indication for bariatric surgery is a BMI above 40 or above 35 with an obesity-related comorbidity, like hypertension, hyperlipidemia, GERD, osteoarthritis. 2 years ago, the American Society for Metabolic and Bariatric Surgery released new guidelines where they actually recommended dropping those numbers down to a BMI of 35 or 30 with an obesity-related comorbidity. Now, that hasn't translated into standard of care yet, but I hope that happens soon. Okay, our medical history has some more notorious misses. In the 50s and 60s, we treated obesity with thyroid hormone and amphetamines. Everybody here is old enough to know about fen-phen. But then we've sort of figured out what we're doing. So we do have medications that work to help patients lose weight. But the scope of weight loss that we see with these compared to bariatric surgery is quite small, and some of them have side effects, and particularly cardiac side effects, limiting their applicability in our patient population. Right now, in the United States, we have 4 medications that are FDA approved for weight loss: orlistat, phentermine and topiramate, naltrexone and bupropion, and liraglutide and semaglutide. And then finally, we also have some data about nutrition and weight. And we know, for instance, from Predimed, that consuming a Mediterranean diet plus nuts can decrease the prevalence of metabolic syndrome by 14% versus just 2% in the control group. This dietary pattern can also reduce the amount of visceral fat patients have, shown here in blue. So I feel like we have all these tools that we know, at least in literature, in sort of controlled settings, works to help patients lose weight. But clearly on a population level, that we're not seeing the results that we want to see. And so what I'm going to do now is talk about some of the newer concepts in obesity that will hopefully shed some light on where our treatment gaps are and how we can fix them going forward. By the end of the hour, I hope that you recognize obesity as a chronic disease that we as cardiologists must treat, and that you're able to contrast some weight loss medication and nutrition treatments for your patients. So let's talk about the pathophysiology of obesity. How many of you have said to a patient, weight management is as simple as calories in and calories out? It's cool. I said that to patients too, until I learned a little bit more and learned that that was wrong. There is so much more, like sleep and basal metabolic rate and physical activity, that impacts our weight besides calories. So this is an inaccurate statement. Another myth that I want to bust today is that genes don't matter. They do. And in fact, they can explain up to 70% of the variation that we see in obesity. I don't know if any of you are binging that Netflix special on omnivore and vegan diets in twins. I'm partway through, but I know that the punchline is genetics matter. And the last myth that I want to bust today is that BMI is the best measure of obesity. It's a good measure and it's very easy to obtain, and we have a lot of data based on it. But its prognostic value is not the same in all groups of people, and it's not a perfect measure. So I use it as an initial screening tool, but I rely on other things like waist circumference and energy level and hemoglobin A1C to get a better sense of my patient's health risk. And I should have said this disclaimer at the beginning. I want to be clear that I'm speaking about obesity as a medical diagnosis with increased morbidity and mortality. I'm not talking about fat or anything about ideal body size and shape during this talk. Okay. The other thing to know about obesity is that, like heart failure with preserved ejection fraction, it is more of a sort of category or basket of diagnoses. So patients who have class 3 obesity have a very different prognosis than patients who have class 1 obesity. And within the group of patients who meet diagnostic criteria for obesity, there are some who qualify as metabolically healthy obesity and some who qualify as having high fitness. So we're going to talk about those two concepts now. Metabolically healthy obesity is the idea that a patient meets criteria for obesity by BMI or percent body fat, but that they have pretty good metabolic parameters, okay? So depending on how we define it, the prevalence is somewhere around 20 to 30%. And what we know is that even though these patients have obesity, they have a much, much better prognosis than their counterparts who have poor metabolic profiles. And if we look a little closer at their phenotype, we can see that compared to patients with obesity who generally have reduced insulin sensitivity, patients with metabolically healthy obesity tend to have more preserved insulin sensitivity, they have less visceral fat, and their inflammatory markers tend to be lower. We know this phenotype is a little bit more common in women than men and a little more common in younger patients than older patients. And there's this hypothesis that perhaps it's a transition state, but we don't know for sure. The other concept that we have to understand when we're talking about obesity is fitness. So fitness is determined by our genetics, but also hugely and importantly, modifiably by our physical activity. And it is a protective factor for obesity. And honestly, it seems to matter more than weight. So if we look at these patients who are overweight or obese, you can see that by being fit, they are dramatically reducing their mortality risk. In fact, I read a paper that said each additional metabolic equivalent that a patient can perform decreases their mortality 12%. Here's some more data showing the same thing. This is a meta-analysis of patients with obesity, and you can see that if we look at patients who are unfit, which is generally described as being in the lowest quintile of physical activity, their risk for death is higher, a little above 2. Versus if we look at patients with obesity who are fit, you can see that that diamond almost crosses 1, their risk is substantially attenuated. And actually, there's this idea that having good physical fitness may even sort of cancel out the impact of obesity in terms of prognosis. Okay, so this is the total regulation of our weight, which of course is very complicated. But luckily for us, we can simplify it to these sort of 5 main components. So our intake, our GI hormones, our genetics, our central nervous system hormones, and our physical activity all come together to create our body's set point. And what's important for you to understand is that for your patients with obesity, once that set point has been pushed to a higher number, it stays there. So even just 6 months of extra weight means that that patient that is sort of constantly fighting an uphill battle to bring that number down and to maintain it. Okay, so we know that obesity is related to cardiac disease, coronary disease, heart failure, atrial fibrillation. And I think most of us were taught that this is mediated via comorbidities like hypertension, hyperlipidemia, diabetes, and obstructive sleep apnea. That's true, but what's also true is that there is a direct link between obesity and cardiovascular disease. Okay, obesity is a chronic inflammatory disease. And we know now that fatty tissue is not inert. It releases hormones that decrease insulin resistance, cause systemic inflammation, and induce endothelial dysfunction and hypercoagulability. And so there is even after adjusting for all of these comorbidities, we find that patients with obesity tend to have worse cardiac disease. Okay, so now that we have some similar background and we've understood some of the pathophysiology concepts in obesity, now I'm going to talk about the newer weight loss medications and why I'm so excited that these treatment options have huge potential. So as I said, a fair amount of our weight is centrally regulated. And this wasn't really something I understood well until I studied obesity medicine. GLP-1 and GIP are both gut hormones that belong to a class called incretins, and they're released after a meal. And here's what they do. GLP-1 in the stomach and pancreas delays gastric emptying, so it helps patients feel fuller longer. And it also increases insulin synthesis and decreases glucagon production. In the liver, GLP-1 decreases gluconeogenesis, and in our skeletal muscle, it causes increased uptake of glucose. And in the brain, and this is the big one, it works on the hypothalamus to decrease our appetite. So patients will have early satiety. And when you read testimonials from patients who are taking GLP-1 agonists, this is really the one that hits home. They'll say, I just feel fuller. I'm just not as hungry all the time. I'm not thinking about food all the time the way that I used to. There's also some data that there may be neuroprotective effects for GLP-1 agonists. So semaglutide, which all of us know and many of us hopefully have prescribed, is a GLP-1 agonist like liraglutide, but induces significantly more weight loss. So in this landmark study, about 70% of patients experienced 10% weight loss. So up until now, I would say weight loss medications have induced weight loss practically in the 2 to 5% range. And so 10% of body weight being lost is a huge, huge improvement. And semaglutide also has a number of other favorable cardiovascular benefits. So we know that it decreases blood pressure, improves our lipid profile, and decreases our hemoglobin A1C. It also decreases our body weight, and everybody knows from the SELECT trial that it actually reduces cardiovascular outcome, adverse cardiac events, which they defined as cardiac death, non-fatal MI, and stroke. But GLP-1 agonists can also have anticoagulant and anti-inflammatory effects, and all of these come together to synergistically show the beneficial profile that we see for patients who are taking these medications. They are generally pretty well tolerated. Most of the side effects happen in the GI category, nausea, vomiting, and diarrhea. The discontinuation rate is somewhere around 10%. And the patients that we need to be careful about prescribing semaglutide or other GLP-1 agonists to are those who have severe gastroparesis or IBD because it delays gastric emptying. There are case reports of acute pancreatitis in response to this medication. So it's not an absolute contraindication, but in someone with a history of pancreatitis, you may want to be cautious. There's some animal data that GLP-1 agonists can induce thyroid hyperplasia. So it's generally recommended to avoid in patients who have medullary thyroid cancer or any of the family history of the MEN syndromes. And then it's renally cleared. So we need more clinical data to understand how we should be dosing this for patients who have moderate renal dysfunction. Okay, that's semaglutide. If we look at Emory's numbers, this is for the month of October across the Emory healthcare system, the number of prescriptions that were written for semaglutide to scale. And this is the number of prescriptions that were written for rosuvastatin. Now, I know there are many, many other factors that are impacting the prescription of both of these medications, but my point here is that I think this is a medication that we are under-prescribing. Tirzepatide is also a new medication that was just approved by the FDA in November for weight loss, and it is a combination GLP-1 and GIP agonist. So again, we can see that 60% of patients experience 20% reductions in their body weight. I'm going to say that again because that number is just amazing. More than half of the patients who took this drug experienced a 20% drop in their body weight at the 10 or 15 milligram dose. That's huge. And like semaglutide, we see a number of favorable cardiovascular markers improve, a number of favorable improvements in cardiovascular markers. And then the last drug that you should be looking out for is a medication called retatrutide, which is a triple GLP-1, GIP, and glucagon agonist. This data was published last year. This is the phase 2 trial for this drug. 70% of patients experienced a 15% weight loss. Okay, so I'm going to pause here and let you process this data for a moment. Semaglutide is known as Ozempic when it's given for diabetes and Wegovy when it's given for weight loss. Tirzepatide is known as Mounjaro when it's given for diabetes and Zepbound when it's given for weight loss. But I'm going to pause and let you process sort of the improvements that we see. So you can appreciate that we are seeing dramatic improvements in not only weight, but also many metabolic parameters that matter to us. Currently in the United States, weight loss medications are approved for patients who have a BMI above 30 or above 27 with an obesity-related comorbidity. So where do we go next? The phase 3 trial of retatrutide, which is that triple agonist, should be finished sometime next year. There is a cardiovascular outcomes trial ongoing for tirzepatide, which is anticipated to be completed in October of this year. And then we'll have to talk about long-term weight maintenance, because I imagine this is a question that many of you are getting from your patients. And I now think about obesity the way I think about hypertension, in that medical treatment will probably be lifelong. Because here's what happens. When we give patients semaglutide, they lose weight. And for the patients who continue taking semaglutide, they continue to lose weight. And actually, we don't even really see it start to plateau until closer to a year and a few months out. But patients who are switched back to the placebo end up having a rebound in their weight. The problem is we don't know about the long-term effects of these medications and if there's anything to anticipate there. So lots of new things to watch for and some unanswered questions, but so far all of the data we have is showing me that these are good medications that we should be utilizing more. Okay. I want to take some time to talk about nutrition, because what I have learned in my practical experience is that many patients have big gaps in their education about nutrition. And I think in cardiology, we have a fair amount of data about dietary patterns and their benefit. But again, that doesn't seem to be translating to effective recommendations on an individual clinic encounter level. So this is literature that all of you know very well. We have a number of specific dietary patterns that have been studied for cardiac outcomes and have shown to be favorable. What I have found, I worked at the VA for 4 years and now I'm at Grady. And what I have found with the patients that I've worked with is that although the Mediterranean dietary pattern is nice in theory, in practice, patients often end up overdoing the olive oil and the nuts and the protein portion and sort of underutilizing the fresh fruits and vegetables portion. And from these conversations, I've actually changed to recommending a plant-based diet as my sort of primary choice. And I don't mean strictly vegan or even vegetarian. I just mean taking what you're currently eating and trying to introduce more plants and vegetables into it, and fruits. Some people call it a flexitarian diet, which I like. And I like a plant-based diet for a few reasons. One, I think conceptually it's very easy to understand. Two, it is very broadly culturally applicable, so you can use it to sort of modify what anyone from any background is eating. And three is it's good for the climate. If you didn't know, beef and the agricultural sector are a major contributor to climate change. Okay. This is the best advice I've seen about food. Eat food, not too much, mostly plants. And again, what I've learned from working with patients is that the more specific your actionable items are, the better. So instead of saying decrease the amount of sugar sweetened beverages you're drinking, I will say, you're telling me that you drink 3 to 4 Cokes each day. Can we swap one of those Cokes out for water? Let's try that for a month and then have you come back, see how you're feeling, see what your numbers look like. I've also, and I've spoken with the fellows about this, I've also shifted the way I think about my job a little. I think as physicians, we are trained to identify a disease process and then fix it. And definitely the conversation around nutrition and obesity has to be more of a let's focus on your health as opposed to let's fix a problem, right? Like it's a pretty terrible feeling to constantly be come in and told something is wrong or bad all the time. But if I can work with patients to find something about their obesity that bothers them, lack of energy, shortness of breath, joint pain, and we can sort of become collaborators in trying to fix that problem and improve it, I think that's a more positive spin and it generally opens the door to more effective partnerships. And then I do make some specific recommendations about introducing more vegetables because, again, I think concrete information is helpful. Grady is 2 miles away from a Trader Joe's, so I tell my patients to shop there. They have all of these really wonderful pre-cut combinations of vegetables that are really affordable and really yummy. I also tell patients that frozen vegetables are great. So frozen vegetables are frozen at the peak of their freshness, and there's some data that they may actually contain more vitamin A, C, E, and folate than fresh vegetables. Plus they last longer and it's fewer trips to the grocery store. And then the last thing I tell patients is try to get a variety in terms of color and number of vegetables. So when I'm meal planning for my family on Sundays, when I'm setting up the menu for the week, I try to hit all the colors of the rainbow: red, orange, yellow, light green, dark green, blue/purple. This handle that I've included at the bottom on TikTok is this the chef who had a video go viral a couple of months ago, last month, where he said, when you go grocery shopping, your cart should have 6 vegetables, 5 fruits, 4 proteins, 3 starches, 2 sauces, and 1 fun item. And I'm really a big fan of very concrete ideas like that because I think that actually translates to information that patients can use as opposed to a sort of generic handout about healthy foods. Okay, other practical tips I've heard: eat foods that look like nature or like something that grows naturally. Avoid foods with very long expiration dates because those are really ultra processed foods. They taste good, but they are not good for us. Shop at the edge of the grocery store. So you hit the fresh produce section, you hit the bakery, you hit the fridge section with protein, you hit the freezer section with protein and vegetables. And then in general, I am in my, I think, 8th year of attending now, and I'm still not entirely sure that I understand carb exchanges. But I do understand that eating foods that are high in protein and fiber are generally is good for me and makes me feel full. And I understand that eating foods that are high in sugar and salt are not so great. So that's what I'll tell patients, and generally aim for complex carbohydrates over refined ones. Practically, this is what I say to a patient. Can we talk about your weight for a minute? I'm worried about your increased risk of heart disease. What have you tried before to lose weight? Almost every single patient I have seen with a BMI in the obesity range has tried something to lose weight before. Nobody enjoys feeling short of breath or feeling like they don't have the energy to interact with their family and friends. So I think it's safe to make that assumption, and you can start there. And like I said, I will try to find other measures that are important to the patient or that are more identifiable to them, like energy level, bloating, joint pain, and sleep. And then more objective measures like abdominal circumference and how many medications they're on. And in clinic, I'll do a 24-hour dietary recall with them. We'll make a consensus decision about one change that we want to make, and then I'll have them come back and follow up for that accountability piece. So I think everyone who's listening to this talk knows these are the foods we should be eating: fruits, vegetables, whole grains. These are the foods that are not so good for us: processed meats, sugar-sweetened beverages, trans fats. But I'm not sure that everybody in here knows all of the drivers of poor diet quality. So we've already talked about lack of knowledge, lack of availability and access, and cost of healthy food can be prohibitive, and that ultra-processed foods taste really good. But I want to ask the audience members, how many of you are responsible for the food in your household? Do you make the decision about what's going to be served? Do you make the list for grocery shopping? Do you actually do the grocery shopping? Because all of those things take a lot of time if you're trying to do it well and eat healthy. How much do you know about marketing and branding about food? We're going to talk about that in just a minute. And finally, every culture has different norms about what is sort of ideal in terms of body size and shape. And of course, within cultures, families vary too. So there's no one size fits all here. Okay, so we talked about some of the pathophysiology of obesity. I've told you about weight loss and medications because I think those are effective, non-invasive treatments that we have that we are underutilizing currently. And so now I want to talk a little bit about how we as cardiologists can do our part to help move the needle on this, because obesity is so prevalent that it's only going to get better if we all step up. This is no longer a problem that we can delegate to primary care physicians. So the first thing I want to talk about is education. And the first part of that is educating ourselves. So our society has an inherent bias against people of higher weight. This is a link to the implicit association test from Harvard. And they have a bunch of categories, but I take the one on weight about once a year just to remind myself of my bias and to make sure I'm doing whatever I can to actively combat it. Talking for a long time on this slide because I'm hoping that some of you are going to screenshot this and take the test yourself. All right. The second piece of education is really what I hope to accomplish over my career. So if we look at a week of patients that we see in the Fellows Clinic at Grady, about a quarter of our patients fall into the normal weight range, and the rest are split between being overweight and having obesity. Okay? And if we look at how we treat them, at the bottom, I've grouped notes by BMI range. Red means that these patients have overweight or obesity, and we didn't mention it at all in the assessment and plan. Yellow means we mentioned in the assessment that they have obesity, but we didn't make a plan for it. And green means that we mentioned obesity and we made a plan for it. I'm going to pause here for a moment and give a shout out to Matt T. Brown, Q, and Rahul, because you guys make up like 95% of the green in these boxes. But my point is we can do better. The same way we address hypertension at every single clinic visit and hyperlipidemia at every single clinic visit, we need to be addressing obesity for our patients who have it at every single clinic visit. Okay, the second part of actually fixing this problem is advocacy work. So the University of Connecticut has a Rudd Center for Food Politics that I think is really wonderful and has tons of tremendous resources. For instance, this is to scale the amount of money that the food and drink industry spend on marketing, $14 billion, compared to how much money the CDC has on chronic disease prevention and health promotion, which is $1 billion. And that's not just for obesity, that's for all chronic diseases. So you look at a slide like this, and perhaps it's not so surprising that so many people in our country have obesity. This is also a picture from the Rudd Center, and this shows that Black and Hispanic children who have, so Black and Hispanic patients have some of the highest rates of obesity in our country, and Black and Hispanic children have almost 7 times as much commercial money spent towards marketing unhealthy foods as they do healthy foods. And then finally, media portrayal matters. So the picture on the left is from an article about rates of obesity in African-American women that was published on ABC a few years ago. The picture on the right is a picture from the Rudd Center. And you can see that the picture on the left is very dehumanizing. She doesn't have a head. She's sitting and doing a sedentary activity, versus the one on the left shows a whole person doing something active. And so, I think most of us don't have the same emotional reaction to both of these pictures, and I want us to be cognizant of the way obesity is portrayed in our society. There's a book called Hunger by Roxane Gay that's very insightful, and also gives some good information if you're looking for more learning. Okay, so what can we do to help? The answer is lots, because little steps do add up to big changes. So you can get involved with expressing your opinion in terms of agricultural policy. The sugar industry does not need that much protection, and it's really not fair that Black and Hispanic kids in our country are being so unfairly targeted by marketing. You can ask for nutritional labeling. So there's data that nutritional labeling on an individual level can decrease the amount of fat and increase the amount of vegetables that consumers take in. And on a food production level, it can decrease the amount of salt and trans fat that suppliers are putting into their food. You can look at your local school and workplace. So at Grady, there's one place where I can buy fresh fruits and vegetables, and that's the cafeteria. But we have a Starbucks, and on every single floor, we have a vending machine. Is that true for you where you work? Is that true for your kids where they go to school? Do they have juices and sodas readily available? And then finally, the CDC's Early Care and Education page has some good resources on combating obesity at a local level. And then the last piece of what I mean by a call to action is innovation. So I'm going to pause here and let you read this quotation. So this is from a letter from Victor Zhao, who gave medicine grand rounds a few weeks ago. But basically, I've come to the realization that although we have things like food tracking apps and standing desks, those are really not going to be enough to fix the obesity epidemic, and we're really going to have to think outside of the box to fix this problem. So I said at the beginning that I wanted you to understand obesity is a chronic disease that we must treat. And I hope you take any or all of these problems as reasons for you to step up and start doing your part in this. And that you're able to contrast weight loss medication and nutrition treatments for obesity. So we talked about semaglutide, which is a very effective GLP-1 agonist that's underprescribed. We talked about tirzepatide, which is a combination GLP-1 and GIP agonist. Talked about a plant-based diet. And I shared some of my thoughts about how education, advocacy, and innovation are probably the answers to fixing this problem. This is a picture of my dad and me at the obesity medicine conference that we went to. And I wanted to thank Mark Thames and Priya Kohli for looking at my slides. I'm going to pause on this slide in case there are any questions, but I've linked for you here some articles that I think are good summaries in terms of further reading, and then some very specific resources for plant-based eating that I share with my patients. Thank you for your time this morning.
Thank you, Lakshmi. That was wonderful. And got a lot of information and some practical tips. I'll start off with a question while I'm waiting for people to type in their questions in the chat or unmute. When you refer to metabolically healthy obesity, are those more likely to be, I mean, is that based on BMI? And then is that more in men versus women? Because I guess what I'm wondering is it that they have more muscle? You know, is that what makes it metabolically healthy?
Yeah, so we don't really have a good consensus definition, which is part of the problem. But this obesity and cardiovascular disease article I've linked here tries to make one. If you look at patients with obesity as defined by BMI, and then patients who, of the 5 criteria for metabolic syndrome, meet either 0 or 1, that's the definition. In general, patients who have obesity tend to have more fat mass, but they also tend to have more fat-free mass. And if we sort of quantify that fat-free mass, it also seems to track with prognosis. So it doesn't, in a pure sort of numbers, from a numbers standpoint, it doesn't seem to be just the fat mass that's affected, because obviously the load is higher, and so they need to have sort of more load-bearing tissue. That also tends to be higher. So I don't know how much has been done, honestly, into sex-based differences here. And obviously for women, it gets a little bit complicated too, because of hormones and, you know, pregnancy and childbirth and all those things. And there's a lot we don't know about it. So there's sort of, I think there are people in the obesity world who feel like this is a very distinct phenotype, and these patients are not at the same risk as other patients with obesity. But there are other people who feel like this is just a transition state. And if you follow these patients for 5 more years or 10 more years, you'll actually start to see that their metabolic markers also worsen. So I don't think we have the answer to that.
There's a question from Modele. Advocacy also includes food as medicine initiatives. Increased focus now on this by HHAS, AHA funding now available to study this. Could you comment on this?
Yeah, absolutely. Yes, that's absolutely true. And I should have mentioned, so Grady has a food as medicine program where patients who screen in for food insecurity can come, they get some education, and every week they get a box of vegetables to take home, and that is their medication, and it's awesome. BMC has in Boston, has a really effective teaching kitchen where they do classes, I think, a couple of times a week, and they also have a food pantry. And I might be mistaken because it's been a while since I last looked into this, but I believe they have a food pantry that's just open and people can go and sort of get what they need. Patients who may not otherwise have access to sort of fresh vegetables or healthier food options. And that's what I mean when I say it doesn't stop at the clinic door, and we're really going to have to look at some of the societal barriers to getting healthy food.
Andy Smith has a question.
Yes, could you comment on what impact it has on you as a physician when you see that a patient has evidence of fatty liver on a CT scan or that type of thing? And I've looked up, a number of centers have developed fatty liver disease centers, and a number of them in their dietary recommendations do recommend that patients take several tablespoons of olive oil a day, and I was interested in your comments about that.
That's a good question. I don't know the answer to that, Dr. Smith. I mean, at Grady, I think it's probably a little bit of a different patient population that we're dealing with. And I am not, I don't know the answer about specifically olive oil and fatty liver disease, but I'll find out and get back to you.
Lakshmi, Stan Sherman. We talked about medicines, and these are shots for the most part. Are there pills coming around that we can use instead of shots, for weight loss?
There are, I think there's one form of a GLP-1 agonist that's available in a pill form, and I suspect more will be coming. I hope more will be coming with combination therapy also. I see this note from Dr. Lundberg, GLP-1 agonists, cost and supply issues are so limiting, and prior authorization takes staff time. Any recommendations for getting drug approved? I don't have a great answer for you, and it is fair to say that much of this knowledge is sort of book and literature-based knowledge as opposed to practical experience for the reasons that you mentioned. I do think specifically that GLP-1 agonists are much easier to get in patients who have diabetes, and I think a fair number of these patients do have diabetes, so that's potentially one avenue. I can tell you at Grady what the pharmacy team is trying to do is liraglutide is given for diabetes at the 1.8 milligram dose, but at a higher dose has been shown to be effective for weight loss. And that's apparently much easier for us to get than semaglutide is. And so they are building into Epic an order set to make it much easier for prescribers to order that medication at the weight loss regimen. I think if we're gonna, what we should be having is a bariatric center, right? So Midtown has a bariatric center, and I think it's mostly for patients who are doing that medical weight loss program before they undergo surgery. But I think if we're going to make progress on this, we have to say that this is a priority and to have some dedicated clinic resources to get at some of this prior authorization. But I don't know, I think there's also advocacy work that we can do in terms of trying to get weight loss medications approved. And that's probably the other avenue to see progress.
Lakshmi, have you heard of, in terms of surveillance? So, these medications, if people are on it long term, because if you stop it, then they gain the weight back. So are there something in terms of thyroid or pancreas, or is there something that we should be checking after a year or 2 or 3? Have you heard anything about that?
Sure. That's a good question. I'm not aware of any formal recommendations to be checking anything apart from sort of a history, maybe suggesting a relative contraindication. I think based on what I've read, it would be reasonable probably to check, I would say, thyroid hormone, LFTs, and maybe renal function, just to be sure that the medication can be cleared properly.
I'll ask one more question. For metformin, before it used to be that if there's prediabetes and a little bit of weight, then you start with metformin. And I know that people are sort of, trying to get away from that. What is your practice? Are you doing metformin and then adding the GLP-1, or are you just going directly to GLP-1, assuming that their insurance will cover it?
No, I'm doing the metformin first. I still feel like it's a good medication and effective and certainly much easier to get. And, I don't know, like even if we prescribe the medication, I don't know how many patients are coming back and saying, I wasn't able to get this, or there are too many steps and they're prohibiting me from actually proceeding with it. My mom works in a pharmacy and she was saying that they're not prescribing as much semaglutide anymore, but she's like, prescriptions for tirzepatide have sort of gone through the roof. Like we're really filling a lot of those. So I think there's a lot of regional variation, and obviously coverage is an issue, and depending on basically how, I was talking with Chelsea Yost, who's the medical director of the bariatric clinic over at Midtown. And, she was sharing that one of her concerns is this going to be another disease where sort of wealthy patients are able to afford treatment and to get it and improve their health, but perhaps the patients who may benefit from it more aren't going to have access to it. But that's also why I think, apart from, I like weight loss medications. I think they're incredibly effective and underutilized. but I don't know how as an individual cardiologist I can fix the payment coverage issue. But I do feel like there are huge strides in education about nutrition and physical activity that we can actually make. I don't know how many of you attended Emory's Learning to Be Better Teachers conference. It was a couple of weeks ago, but there was a professor from Georgia Tech there who was talking about innovation. And he was basically saying, and this really struck home for me, people are experts in their own lives. So they are doing what works best for them. And if you want to change that behavior, you have to find a way to do so that basically makes their current approach undesirable. And so I think about that a lot when I think about how can I actually help my patients change the way they eat or change the way they move their bodies or change the way they sleep, because all of those things do help us lose weight. They're just difficult to do in our society now.
Great. Thank
It's
you
Pe-
again. Oh,
It's Peter. Can I ask a quick question?
yes,
Or are we running out
absolutely.
of time?
No, we have time. Go ahead.
Okay, so I've been around long enough so that I know that back when I started out, everyone was supposed to look like Barbie. And then over the course of my career anyway, it seems to me that everything is gradually changing, and now it's okay to be overweight, and it's okay not to eat good foods and so forth. And particularly because of the TV ads and things that happen on TV where now everybody looks like they are overweight, in short. Because I think that's a societal issue. And it bothers me a little bit that it's wonderful that we all try to do the best we can with our patients, but it seems to me we're swimming upstream against the current. Isn't there some way to make the national movement of making things better in terms of nutrition and so forth a little more palpable and easily digestible for the general public? It seems to me that we're, as physicians, sort of on the corner of all this, doing the best we can, but there's a lot of stuff out there that says, well, it really doesn't make any difference, and oh, by the way, it's okay to be fat. How do you feel about that?
That's a lot in that question. I guess the short answer is yes, I agree. The longer answer is a few thoughts. So one is, I will say that I think that not all physicians are aware of all of the barriers that some of our patients have to getting healthy food. So I think when we sit in the clinic room and we say, you need to eat healthier, you need to eat more vegetables, you need to eat less processed meats, that doesn't necessarily account for how much of that is realistically possible. And that's not a burden that should be placed on the physician, I agree, but it's not a burden that should be placed on the patient, right? So there's so much of that has to do with kind of society and government and advocacy and lobbying. And if you read about the food and drink industry, Marion Nestle has this book called Soda Politics that talks about how protected the soda industry is in terms of lobbying and how much money they spend. Like, the more I learn about that, the more I feel like for each individual patient, it is an uphill battle. And I actually do feel like, as a physician, if my goal is to improve the health of my patients, that's maybe an area where I can push a little bit. So I guess one thing I want to say is that or if you look at like portion sizes in the 1950s are dramatically different. I think they're like a fourth as big as they are now if you go to sort of an average fast food restaurant, right? And I didn't share data today on food deserts and food swamps, but all of those things matter. So that to me is not a media piece. It's just the reality of what patients are facing. And I think if we're not acknowledging that and trying to do what we can to fix that, then we are being a little unfair. In terms of the media portrayal, I understand what you're saying and I agree. Last year I talked to the medical students about obesity and I got some questions about fat shaming and being fat phobic and and that's not my intent here. And I really want to be clear that I'm talking about the adverse prognostic prognosis that we see associated with obesity. So I think some of that is maybe having, and maybe BMI is not the best measure because it has been shown to be a racist metric in some groups. Like, maybe that's not the thing that we should be focusing on. Maybe we need some more consensus about what's your energy level? What's your waist circumference and how much visceral fat do you have? Because those tend to be stronger predictors of overall health. And perhaps if we change the focus of what we were looking at from weight to something else, that might make it easier for all of us to partner together. But some of that I don't know the answer to. Like I think body positivity is a wonderful thing, but it's also hard for me to look at someone who has a BMI of 35 or 40 and to not be concerned about the adverse health risk that patient may be facing as a result of their extra weight.
Isn't there some way we can get the government to be involved a little bit more? I can actually remember John Kennedy, who, when he was president, began this program of physical fitness and getting people into the gym and losing weight and so forth. And it seems to me since that time, granted, I understand the issues and how difficult it is to deal with healthcare in general, much less this specific portion of healthcare. But it seems to me that we could do better, not we personally, but the world could do better, in the United States particularly, by having national associations associated with this whole push to try and improve understanding of what is and what is not sort of good for you versus bad for you.
Yeah, I think that's fair. Although, I think Michelle Obama had the Let's Move campaign and she focused a lot on childhood obesity and childhood healthy eating. And, I'm not sure how much of a needle she was able to move there, but the emphasis was coming from above. The Obesity Medicine Association is the professional society that I think of as being analogous to ACC. It's a little bit more clinically focused. The Obesity Society is a little bit more of a research-focused society. But both of those groups do have advocacy work that they do, and I'm happy to connect you offline to their resources about places where we as physicians can use our voice to try to help with some of these things, like do patients have access to good food? Do they have a safe place to exercise? Can they afford to go home at night and sleep, or are they doing working 2 jobs to maintain their family or to support their family? All of those things matter.
Peter Stan Sherman, I think that if you look at the slide she had on the amount of money spent on pushing foods that aren't particularly good for you, that tells you a lot about advocacy right there. But I think just from the Emory standpoint, it would be good if we had a handout for patients. I think that could be developed that at least says this is what you think we ought to be eating, instead of what patients do eat.
Absolutely. And ACC's CardioSmart has some good patient-friendly handouts, so I can send those over and share them with the group.
That'd be great.
Starting place. Yeah.
Neil has a comment here.
Coming out-of-pocket price caps for patients with Part D will likely have a significant impact on affordability for these meds for patients over 65. So what I was told by the pharmacists at Grady is that Medicare decided a long, long time ago that they were never going to cover weight loss medications. So I don't know if anyone in the group knows more about that, or if that's true, or if we have to wait until they become generic.
This is Neil. I wrote that comment, and I don't have a lot of insights on the extent to which they're likely to be covered. I do think, in lots of our patients with comorbidities, the sort of fixed out-of-pocket cap of $2,000 per year will have a big impact on their access to lots of medicines that are otherwise expensive. So yeah, it was more about that than about so certainly patients with diabetes for which this is covered, those kinds of things that I do think it probably will have an impact. But your bigger question about access for weight loss drugs is an interesting, very different issue.
Any other questions or comments? Again, Lakshmi, that was wonderful, and thank you so much for doing this for us this morning.
Yeah, absolutely. Thank you for the thoughtful questions, and I know there's a couple of things I left unresolved, so I will follow up with some answers shortly.
Okay, great. Thank you, everyone, and I will see you next week.
The preceding program is copyrighted by Emory University.